Adesso ci colleghiamo, in collegamento siamo con Pierre Kory. Sì? Ok, allora ci colleghiamo con Pierre Kory. Grazie.
Hello? Shall I begin? Do you want me to share my slides?
Yes, please.
Okay. I'm not allowed to share it. The host disabled my screen sharing.
Okay. Hi, Kory.
Okay, so thank you. So buongiorno. I'm Dr. Pierre Kory, the President and Chief Medical Officer of the Frontline COVID-19 Critical Care Alliance. Could you go next slide? And I've been asked to talk about the treatment of the hospitalized patients. And so I'm going to briefly go over some of the main therapies that we use. This is our Math Plus treatment protocol. It is a combination therapy. This is a very complex disease, especially in the hospital phase. And we use a number of different therapeutic strategies trying to attack a number of the pathophysiologic mechanisms. So the protocol it's called Math Plus for a reason, because the core therapies are right here: methylprednisolone, ascorbic acid, thiamine, and heparin, so for anticoagulation. Next slide. We also have first-line therapies that we have added. As more evidence comes out and we learn more about the disease, we've added highly effective therapies. So we have antiviral and anti-inflammatory therapies in ivermectin and nitazoxanide. The most important new development in the treatment of the hospitalized patient, in my opinion, which is a true game changer, is the anti-androgen therapy. It is highly, highly effective, and we are now using it with great success. We also use active vitamin D and melatonin. Next slide. We even have second-line adjunctive therapies, which are also evidence-based, which we have found helpful, and we use in the more severe cases. So that's just a brief overview. So those are 3 slides showing our core therapies, our first line and second line. So if you're overwhelmed by the number of medicines, I will tell you, we usually don't use this many medicines in a single disease. But like I said, this is, as my colleague, Professor Paul Marek, says, this is the most complex disease that we have encountered in our careers. Next slide. Now, although I talk about, and by the way, I missed the slide about myself and my background. So for everyone to know, I am a lung doctor as well as an ICU doctor. And I'm talking about the hospitalized patient, but I want to be really clear. The treatments that we propose need to be started on admission to the hospital. You know, when you look at the phases of this disease, it is one of tragic undertreatment at every phase. There is underutilization of preventive therapies. For instance, ivermectin, in order to prevent disease, is widely underutilized across the world. So we're seeing more disease than we should. So prevention is undertreated. Early outpatient treatment is undertreated. There's almost no protocols for early outpatient treatment at the national or international level. In the hospital, it is wickedly undertreated. I am constantly getting patients who arrive in my intensive care unit, and please, everyone understand that as you progress from well to ill to hospital and then to ICU, the intensive care unit is the end of the line. It is very difficult for me to turn around an ICU patient. Every day delay with starting therapy makes for a worse prognosis. And so again, although I'm an ICU patient, I want a doctor, I want everyone to understand all of these therapies should be started on admission to the hospital to prevent ventilation and prevent ICU. So as you can see, there's a number of strategies that we do. I'll first talk about the anti-inflammatory strategy. So when you go to the hospitalized patient is essentially defined as having lung disease in most instances. Sometimes it's clots, which bring them to the hospital. Most of the time, it's lung inflammation, and they need oxygen. That's who's getting admitted. Next slide. So just so you know, we've had steroids in our protocol since last April. We knew it was life-saving. And our first protocol, when it came out, the entire world was against it. Every single national, international health agency said to avoid it. I testified in the United States Senate last May, and I was widely criticized around the country and the world for saying that steroids were critical and life-saving. It was not until 6 weeks later that it was proven and developed a standard of care worldwide. Next slide. Next slide. That's a paper that I wrote a long time ago showing the critical need for steroids in this disease, because it's really one of an organizing pneumonia. Everyone should understand this is a disease of macrophage activation, severe inflammation, which attack the lungs. And so anti-inflammatory therapy is critical. Now, this is another very important point. This slide shows the reductions in death with steroids using different agents. Here in blue is what we propose, which is methylprednisolone. This is hydrocortisone. This is dexamethasone. I want to make a really key point. The entire world is using dexamethasone at 6 milligrams a day. It is highly ineffectual. It saves the few and fails the many. People are dying across the world from undertreatment with steroids. And the reason why I say that is this number right here. It's called the number needed to treat to save one life. And it's a measure of the power of a therapy. Lower numbers are much more powerful. If you look at this study, 250 milligrams for 3 days showed a massive reduction in death. Same thing with methylprednisolone at a higher dose. This is the dexamethasone. It is a much, much weaker a strategy, and people are dying based on that. Yet everyone around the world is getting this low dose of dexamethasone, and it is a crime that I have to watch this. And I'm seeing people come to my ICU and dying from undertreatment. These are studies which compared methylprednisolone in our protocol versus dexamethasone directly. And the number needed to treat to save one life if you use methylprednisolone is 5. It is far superior. I cannot stress this enough. Next slide. We also use intravenous vitamin C. I want the world to recognize that in severe lung injury and ARDS, a major randomized controlled trial found that mortality was significantly reduced. This is in non-COVID, but there's a major mortality benefit if you used high doses of intravenous vitamin C. We do the same in COVID, and there's a number of studies showing mortality benefits. Not as large as this, but that is why we use it. Next slide. Now, we talked about anti-inflammation, anticoagulant therapy. Next slide. Absolutely critical. The world has now recognized that. But I have to tell you, again, this was a paper we wrote after seeing my first 5 COVID patients. We did analyses, and we saw they were clotting to a degree we'd never seen before. And we instituted anticoagulation out of protocol last April. And we were also roundly criticized for that until it became the standard of care. Next slide. Now, if you can see, so this is our methylprednisolone, this is our anticoagulation, this is our ascorbic acid, and we have 2 different strategies depending when you start. We do full anticoagulation on admission, and we'll do half dose if you start it later. Next, and that's according to the best evidence that's come out. Many trials have come out supporting our initial strategy. Next slide. Now, antiviral. Now, the key thing here is before Delta, it was largely felt and proven that the virus is no longer replicating by the time you get to the hospital. Most studies cannot find active live virus after about 8 to 10 days from first symptoms. And most people come to the hospital after that. So there may be some viral replication. However, that we believe is changing. With Gamma and Delta, the viral loads are higher, and we think the viral replication phase is longer. So we're still using antivirals. Next slide. The other key thing, so antivirals are ivermectin and nitazoxanide, numerous studies showing massive effects against replication of the virus. The key thing, though, is ivermectin has numerous anti-inflammatory properties. So it's almost it's what we call a gift to us because it has antiviral and anti-inflammatory properties. We use it probably more for anti-inflammatory in the late phase disease in the hospital. And the key thing about it is that in order for it to be most effective, it really has to be given at higher doses in the hospital. Lower doses okay early, higher doses as the disease progresses. Next slide. Now, I happen to be one of the world experts in ivermectin. I was not asked to lecture on it. I'm sure others have covered it, but I will just say briefly. It is essentially the penicillin of COVID. There have been 63 controlled trials, 31 randomized, showing massive potency in preventing the development of disease, incredible improvements and reductions in hospitalization and mortality if you give it early. And you can see that the efficacy wanes the later you give it, but it's still a major improvement in saving lives. It will be a historical and colossal and tragic catastrophe when it's recognized the massive suppression of the use of ivermectin. But the key point here is you have to use it early. And if you give it later, you have to give it higher doses. We are seeing effects now that we're going up in these new variants to higher doses. Next slide. Nitazoxanide, I call it the fraternal twin of ivermectin because it's also an anti-parasite, anti-protozoan drug, but it has numerous antiviral properties, which actually do not overlap with ivermectin. And we have data, it's not published yet, but the combination is better than each one alone. So we try to use both if available. Next slide. Now, here's the major, I think this is the major game-changing therapy, and I think this should be standard of care around the world based on the evidence and the magnitude of benefit. Next slide. And a lot of this work was done by our newest member of my organization, Dr. Flavio Carajani, so I have to call out to him. He has really done immense amount of studies, and he's developed all the insight into this. Now, why would you want to block androgens? And what are androgens? So androgens are essentially the male sex hormones like testosterone and its other more powerful metabolites. And the reason why it's important is because those hormones like testosterone essentially drive and help the virus get into the cell. It regulates an enzyme which allows the virus to attach and enter. And if you actually suppress testosterone and other androgens, you actually limit the ability of the virus to enter. And the magnitude of which this is absolutely incredible. The other thing that anti-androgens do is it suppresses inflammation. Now, how do we know why androgens are so bad? Well, it's well known that males fare worse in this disease. They started noticing in a paper in Spain last year, they saw an ICU where almost everyone was bald. And baldness generally suggests that you have high levels of one of the metabolites of testosterone, and that's why you lose your hair. And contrast that with females and children before puberty who have very low levels of testosterone, they don't really develop severe lung disease. Males are more than 6 times more likely to die if your age is 40 to 45 and twice as likely in the ages of 30 to 50 to go to the hospital. Next slide. So I will just say numerous papers have shown that women who suffer from excess levels of androgen do much worse. Women who have too much androgens who are on therapy against it do much better. Men who are on androgen suppressing therapies do really well. Men with prostate cancer, for whom they are on very high potency anti-androgens, they fare extremely well with COVID. So there's a lot of observational studies, and now there is a number of randomized controlled trials showing massive efficacy if you start anti-androgen therapy in men or women. Early on, it prevents hospital, and later on, it prevents death. Next slide. So this is the proxalutamide trial, very high potency, a novel agent used for prostate cancer. They used it in outpatients, and they saw this massive reduction in the need for hospitalization. Only 2% of this very large trial of men who got the therapy actually needed hospital, whereas a quarter of the men. This is a huge, huge impact. You do not see impacts of most medicines to this degree. It is absolutely, I think, just world-changing. Next slide. What is even more incredible is this slide: 645 hospitalized men and women who are not yet on a ventilator, and they randomized them to proxalutamide. If you look at the last line, I have never seen mortality reductions of this size on a medicine in my life. This would rival antibiotics in infection. 50% of those who didn't get it died versus only 11% died. And if you look at this scale of severity, after treatment, everybody was essentially home and out of the hospital, whereas the controls were all ventilated or dead. It's an absolutely incredible impact. Next slide. But here's the problem, guys, is proxalutamide is not available. It's a novel agent. It's being developed for the use of prostate cancer. So you can't use it. It's very high potency. So what we have done is we've used combinations of anti-androgens to try to mimic the potency of proxalutamide. There is some data, and I have some data from colleagues in Brazil who are showing that these combinations are working very well. So we are trying to do what proxalutamide does. Spironolactone is an old, very safe drug. It's a diuretic, and at these doses, it has powerful anti-androgen properties, and this is also an anti-androgen. If you're sick or in the hospital, we use more high-potent anti-androgens with dutasteride. So these are our protocols, and we use them in both men and women. It has to be started early. Next slide. And so I went over the core therapies, right? The MATH, ivermectin, nitazoxanide, the dual anti-androgen, and then we also have adjunctive therapy. So in the hospitalized patients, fluvoxamine, which is an antidepressant, which has been shown to work in outpatients as preventing hospitalization. And it has numerous anti-inflammatory properties and mechanisms that actually match up pretty well against the mechanisms of COVID. And so in severe cases, we will add fluvoxamine or an alternative, which is fluoxetine. Cyproheptadine is very good at improving hypoxemia in some patients. We have a lot of anecdotal and some clinical case series data on this. And then we also have some drugs that are helpful against antivirals and anti-inflammation. And then we do plasma exchange in really refractory cases of patients that we think are viable, but who have failed therapies. Next slide. Is that my last slide? I think that might be my last slide. So I'm just going to summarize and say that, again, what I just presented to you is a combination of therapies. If you think it looks like a lot, I have to tell you, there's one thing I've learned in this battle, especially in the hospital, is the sicker they get, the more severe they get. And I don't know if everyone's familiar with the term full Monty, but Dr. Marek and myself, we often employ what we call the full Monty, which is every single one of those agents in order to try to help people. I will tell you that before we added the anti-androgen therapy, I was not seeing good responses in the Delta variant in the ICU. Whereas I was turning people around before, the Delta variant, it just has much higher viral loads, more inflammation, and those ICU patients are very difficult to treat. But now that we're getting more aggressive with anti-androgens, we are seeing responses. But I have to tell you, the ICU doctors understand this, but our colleagues who work on the regular floors in the hospital, they're not being aggressive. The entire world is using 6 milligrams of dexamethasone and remdesivir. And remdesivir, I'm sorry, that is a toxic drug of almost no efficacy in the hospital. And so the treatment protocols, again, it is distressing to me to see all the patients coming to me so sick, needing ventilators, when I know that had they been treated more aggressively, they would not need ICU care. And with that, I will stop.